We're doing this presentation because we have had a lot of interest from across the country, not only hospices but acute sector, about how we've embedded outcomes into our clinical practice. I have to reiterate what Sam said at the beginning. We are not standing here today professing this is the way to do it. All we're doing, because people have been asking us, is sharing how we've done it. I'm not going to spend too much time talking because actually Sam's going to tell you the practical steps that we've taken. And we've already heard about a lot of the background to what took us at the start of the journey back in 2013. But by the end of this, I hope that we've given you enough information to see what the challenges for us were, what the priorities for us were, and how we have made those steps. It's a continuous journey. I don't see it ending because everything within our sector is continuously changing, as we all know. So, Sheffield, just to put it in context, we have a population of just over 500,000. We are part of the South Yorkshire metropolitan area, and we support, as an organisation here, Sheffield people. Our inpatient centre is a 20-bedded inpatient centre. We've seen our average length of stay reduce in the 11 years I've been here from 22 days, which was extremely high, to around 15 days, still probably a lot higher than a lot of you have. But I think we feel that that is right for the population and the clients that we're supporting. Our integrated community team see approximately 1,600 patients a year. As Ross said, I'm really interested in that, yes, they see patients, but they also support patients, families and friends. So that figure, I would say you could probably double at least. We have an establishment there of 16.2 community nurses. That said, as we present to you and when Joe and Laura present later, we do not have 16.2 community nurses, and at no time in our journey over the last 4 years have we probably had more than 11.2 community nurses. At best, we've probably had 9.
Yeah, and I think that's probably just to say, so if we think about the data that Stephen presented around Encompass, actually we were presenting that data at times when our service was only with 8 nurses, half of our requirements. So that's why I'm quite, we were struggling, and we've still managed to do quite well. Sorry,
that's all right, don't do it again. Laura is our consultant and works with the team as a 0.7, and we have an SPR, and that's something we didn't have 2 years ago, and it's something that Sam has fought very hard because we can see that community is where the growth and acceleration in our patient cohort sits. We have a newly named team, and that's the Acute Intervention Day Centre. We historically, up until about 2 weeks ago, were a therapies and rehabilitation centre. That did not reflect the activity that was happening in that centre. Those patients are sick. I'm sure you're all seeing that in your day centres, and the team delivering care are delivering acute interventions. And, it bore out the transition in the change of name because we were very much struggling, Sam and I, with our trustees for them to understand why they couldn't just lift day patients from Little Common Lane and bring them here. Well, quite clearly that is not possible because those day patients are seeing nursing and medicine and the allied health professionals, but they critically need nursing and medical interventions on every visit. And they see about 300 patients a year. So, the drivers for change back in 2013, we've already heard a lot about those. I don't profess to repeat them all, but we were in peer review. Sam had just come into post. We were under a remit from our chief executive to look at our MDT working because it was very cathartic, it was a very nice conversation. But actually, if you were lucky, you got discussed as a patient, but the majority of patients probably didn't get a good discussion, particularly in community. On the inpatient centre, because there is a cohort of patients, 20 week in, week out or less, they were discussed, but actually by the last discussion for the last patient, it probably wasn't as good as the first one where we talked about how lovely Nora Jones was and how lovely her family were, and we went all around the houses. So we had to change. We also had a workforce that we knew was not sustainable going forward. At that time, St Luke's had just come out of a very challenging period where we knew 5 years down the line we would be bankrupt if we didn't address the model that we were delivering care and our services per se by. And so we had a key driver that we had to start to do things differently. And we also knew that, you know, recruiting Band 7s to community was becoming increasingly difficult. We have a flat structure of Band 7s, and even bringing a Band 6 district nurse into the team at that time, they didn't have the skill set to become a Band 7. So lots of challenges, along with the national recruitment challenges in nursing per se. Patient outcomes, our organisation, our chairman and our chief exec were, prior to even Oak being around, starting to say to us, it's lovely that you get all these thank you letters, Judith and Sam, but how can you tell me that you are delivering effective care? So we were starting to think of that, and we really stumbled across FLIS and the Oak suite of measures early on, and we're lucky to be part of the Palliative Care Funding Review, which enabled us to start taking the steps to move the organisation forward. That sits alongside organisational outcomes and the business case to actually start to make a change. And I think one of the benefits we've had here at St Luke's is that we've had a very proactive board of trustees and chief executive who have absolutely supported, though it's been challenging at times, us actually moving on this pathway. And the scale of the problem is probably greater today, so we all have to pay attention to this, than it was in 2013, because the projections are up there by 2040, 42% projection increase in patients requiring palliative care. And we know that if we just wind the clock back to 2013, we couldn't have done it. We've still got a challenge to be able to deliver that increase in Sheffield. So, key areas of opportunity. Some of you might know this slide. It's from the Nuffield Trust, a recently published document delivering the benefit of digital healthcare. Sam and I have put it up because we have been talking about digital healthcare during the course of the morning. And EduServer here and Sensory Tech is somewhere around, I think, as well. You can see how technology has enabled us to deliver care in a very different way. But when we looked at those 7 areas of opportunity, we actually felt that Oak was one of the contributing factors at St Luke's that have enabled us to say, do you know what? I think we can tick each of those lines and say we are doing it, or we are on a pathway to doing it. So that's just the context. How have we done it? So the practical considerations. I know Sarah and I have talked about this a lot. Introducing Oak is not just about introducing Oak. It's actually about taking your organisation on a massive culture change. And so to do that, I think you have to go in with eyes wide open. And I have to say, Sam and I did not start this with eyes wide open at all, because we did not realise quite how significant this change was going to be and how high an impact it was going to have, not only on the clinical teams, but the whole of the organisation. So in order to do that, and some of this is the benefit of hindsight, I think, you know, Laura and Joe and Ginny might say, well, yeah, that's great, involve the clinical teams. We perhaps didn't do that as well as we could do, but we're giving you the benefit of our hindsight. So the clinical team's involvement was absolutely, and should be, absolutely critical at every level, alongside the volunteers, because actually when you're talking about organisational culture change, and I'm sure it's the same for all of you, we all operate because we have a huge cohort of volunteers working with us, but those volunteers can at times be quite challenging to us. So we have to, and again, we could have done this better, take the volunteers alongside us. I think this is probably the most important one, but that's just my view, the leadership and ownership. And I have to say, for St Luke's, the fact that the two of us have been absolutely tight on this has meant that the teams have then seen that there's no wiggle room. And we have, not now, but in the early implementation, driven the changes and worked with each of the clinical teams. So the inpatient centre team, community team and therapies team. That's worked for us. Other organisations might be different, but I do feel for those of you in the audience that haven't got your director of patient care and medical director, they are key because they're the people predominantly who will be sitting in the boardroom and who have the direct ear and ability to influence the Chief Executive and the Board of Trustees and other members of the executive team. I think the benefit to patient care has to be understood. I think Ros has touched on some of that. But in doing it, it's not just the clinical team seeing the benefit to patient care, but the IT teams, the administrative teams, because they don't sit in isolation. And our IT team and clinical administrative team have been as key to this working as the clinical teams have. And being transparent, consistent, that's the world we all work in now, and knowing that it actually is going to take a huge amount of time. I couldn't quantify for you the amount of time. I think for Public Health England, we had to try and quantify the time that it had taken of myself and Sam, of IT, and the various other key people involved. And it is really quite considerable, and I think you always underestimate just how much time is going to be needed. And IT readiness stroke capability versus human resource. If you aren't IT ready with the IT functionalities that you need, you have to have the human resource in people to do this. Ideally, you need both. But if you haven't got IT, and you know, for smaller hospices, they might not have the IT structures that we have here, then you've got to have people. And that's why I go back to the leadership and ownership, because, you know, we created new posts here, we had to bid for new monies in order to deliver this. And I'm sure we could have delivered it without new monies and new posts, but it would have been far, far harder. And I'm not sure for our organisation if it would have been so successful. So, objectives, smart objectives, I don't really want to teach you to suck eggs, that's pretty obvious. A Gantt chart, and I hope there's an example of the Gantt chart in your pack.
There is one in the pack, but we will send.
We're going to email them out, are we?
Yeah.
Just so you can get a flavour for what the key milestones along the journey were. So, Sam.
So, I guess the other element of it is about workforce consideration. So, Judith talked absolutely about engagement and ownership of the process amongst all of your clinical teams. And that also goes down to actually the workforce considerations of who's going to actually use the outcome measures at the time you're going to use it. Who will assess the problems that you're using? Who's got the skill set? Because it's one thing deciding, oh, well, actually, the doctors are going to do that as part of their assessment, but actually, do they have the right skill set? And, you know, if you've got a flow through of trainees every 4 months, really, and this is a fundamental part of your system, are they really the right people to be doing the outcome measures when they're going to go away and never do it again? It's a question you've got to ask yourself. Who has the time? I think very early on, certainly in our inpatient centre, where we really started the journey in earnest, we kind of said, it's hard enough for us to get our doctors and nurses on our inpatient centre to fill out all of the documentation that they've got to fill out. If we turn up with another form and insist that they do that, the likelihood of success is fairly low. And so we kind of thought, we're going to have to find someone else to do that. And we ended up, that was where Judith kind of was taking into account the changes in nursing workforce and all the challenges. And we actually said, this is a point for an assistant practitioner, an AP. Our healthcare assistants were absolutely the most consistent part of our workforce. And actually, we're crying out for opportunities, and this was the perfect one. Who are the right people? But it really is setting dependent. I'll skip one there, because actually there's no way we could deliver that in community. We don't have a fleet of APs to go out as part of our process and do that. In hospital settings, we don't have that. So you have to really consider all of these things. And it might be different for every organisation. Your setup might be different from ours, but you just have to think about it. And who has the commitment? Well, our AP, when she first started this journey, she really got the bit between her teeth. I think she was so proud. They were so proud that they'd been given this opportunity. Boy, did they have the commitment. And actually, we've seen them grow in a way that's actually really heartwarming. You know, for our other teams, it's perhaps been harder to convince them of the value of it, but that's a constant piece of work, you know, and so we've got to think about how we manage that. It's very quickly, there's setting challenges, just to talk about them. Your day centre is different from your inpatient centre. Yes, we can use APs in our day centre, we can't use them in community, we can use them in the inpatient centre more. It's actually, you have to think about your setting. You know, are they multi-professional working or are they lone working? So in community, our CNSs, by and large, all ladies, are every woman. They do everything, you know, so they do every part of the assessment. You know, so there aren't really, but in our inpatient setting, it's more of a multi-professional context, so we can have an AP do a bit of the pathway, so doing the iPause, feeding into the handover, entering the data, but the information is being processed by the consultant on the ward round as part of the ward round checklist, and so on. So it's actually having a think about how your processes mesh together to deliver effective care. And then there's obviously the patient case mix. Sometimes, in some settings, the patients are just too sick to engage, and so then you then need to make sure that your staff are able and willing and capable to make those proxy assessments, and that they are aware when those are the right things to do. And then the length and nature of contact, well, if someone's whizzing through for 5 minutes, it's unlikely you're going to get them to sit down and fill the form as efficient as you can make it. So it's just bearing these things in mind. So from 2014, where we started our journey of outcome measures at the start of Oak, when it emerged, we went in 2013 to see iPause talk being given when it was paused, I think then, by FLIS. And since then, to this point, these are the things that we've implemented. So we've seen the modified Karnofsky, phase of illness, iPause, outcome measures, views on care. That's as far as we've got. We are continually flirting with the idea of, Zaret Burden Questionnaire. And we're on the verge of launching that, as trying to draw in the carers element. So, I mean, what was great about Oak was our sense was you didn't have to do every step. You did the steps that fit, and the fit within the context of your process. And then, on top of that, critical components of our working, an MDT coordinator. I mean, I think when we started, the thought of an MDT coordinator kind of drew laughs. But actually it's been an absolutely fundamental component of what we do. The MDT coordinator isn't really just someone sitting in a meeting. They essentially are the pathway coordinator for how the MDT runs. It's linked in with the referral process and the workflows. We had to have our assistant practitioners on the inpatient centre, and that's grown. Our assistant practitioners are now not only taking ownership of the iPods, but they're doing ECGs and doing blood tests and being things in the hospice that we probably didn't imagine that we would have before now. In terms of engagement, the iPods user group was fundamental. Culture change is one of the things that Judith said, and we actually had a user group that met in every week. We sat down, Judith and I, with our clinical teams in every setting that we launched it, to say how is it going, to hear all the concerns raised, and actually to try and say, well, we've had these, or we can explain why, or bear with it, to really kind of keep people engaged in that process. Absolutely fundamental. But as people saw the questions, the same questions come back, the same answers being given, those weekly meetings went to fortnightly, went to monthly, went to 6 months and stopped. Because actually people understood the value, or at least they knew they were going to get the same answer. So, they were engaged, and they had been engaged. So you have to give that time to be successful in our view. And then the MDT chair, a very, very unaccounted for in its importance. The chairing of those meetings is fundamental to actually the success of how they were. We have a very good chair. You'll see her in our video when we show you shortly. But actually, the chair has to command respect, and there is a style to chairing. I think Judith says chairing meetings, never mind just an MDT, is one of the hardest things that you can do to engage everyone. And that is absolutely true for the MDT also. And it's allowed us now to set up proper clinical workflows that mean something and make a difference. And at least from our perspective, where we're sitting, they make a difference on a daily basis, on a weekly basis in MDT. But now what we're starting to see is when you combine those things with the IT, there is a suggestion that they make things on a difference on a macro level for the service that we're delivering. That's the suggestion. We hope that will be borne out further. But in order to do get those clinical workflows properly working, you do need to have them IT supported. and you do need to report. Reporting is fundamental. All the time you need to be reporting in ways you can't begin to imagine at the start of the process. You need to report because it drives patient care. The process of drawing the information stored digitally in an iPOS out of your computer system into your MDT is a form of reporting. The process of discussing your iPOS outcomes in Compass and eShift is a form of reporting. The reporting is fundamental to all of the processes. It has allowed us to change our workflow and support our staff. And it really has, and allocate our staff. But it's also allowed us to help with staff compliance. You know, we brought the community team members, Joe and Laura will smile, but our IT manager used to challenge all of us by presenting us weekly with reports of who had filled out their iPOS and who hadn't. And we would then have to go back to the team and say, you know what, you're really not doing it. We're asking you to do it, why are you not doing it? But actually that reporting is fundamental to get people to do it. And you know, it seems like you're kind of banging a drum, but it's not just you're not beating people with a stick. You're trying to engage people and explain the rationale and the value and why you need to do it. And unless you can report it, what happens is you wind up the little clockwork toy and send it off, and then until it winds down and fades away. The reporting is the thing that keeps the process alive. And then you gather your outcomes, you know, and so we've gathered them, I guess, within our, they'll be available digitally. I don't think they're all in the pack. But again, our outcomes and how we gather them, how we manage them, how we respond to them, again, those smart way of working is really important, but they need to be embedded into everyday practice. So for us, those outcomes are reflected in our handover. It's part of our daily language. It's reflected in our ward round, in our board rounds, in our acuity and dependency and case mix tool. You'll hear a bit about that later. In the way we escalate through the complexity framework, you'll hear about that later. It's embedded in escalation, in our handover to other organisations, to our registrars out of hours. It's embedded in our MDT. It is part of that feedback loop. And unless people can see the outcomes and feel the impact that it has on their clinical delivery, our sense is it's harder for them to engage and it's harder for them to own. So that's where you see this becomes a massive cultural change, a massive process change, a massive organisational change, because you have to find a way not to artificially shoehorn the measures into this, but need to get there quickly. Okay, so you'll see a little bit about effective working, but multi-professional working is essential. And we put them into our MDT, and we'll show you our MDT meeting just now. To give you some historical context, when we started, we think I had, 13.5 hours of MDT meetings a week, 3 separate community consultant-led meetings a week. Consultants don't make great MDT chairs. It's difficult to do the MDT chairing and the actual being a consultant or a medic at the same time. Apologies to consultants who have a different view, but that's my sense. You know, we had barely had a therapies and rehabilitation day centre MDT, and we had 3 separate inpatient centre MDTs, again chaired by the consultants. Massive use of resource, cathartic discussions, no outcomes, not effective, waste of time. You know, and that sounds really harsh, but I think that's where we got to. Things have changed massively. You know, we've had a massive reduction in the meetings, professionally chaired, MDT managed, and those meetings, the information really is a form of governance. So when we sit in those meetings, we can see, we can feel what's happening to our patients, and we can tell whether the care is delivered. We know our clinical teams probably better now for engagement in those meetings than we ever did. When we're not in those meetings, as sometimes time pressures mean that we've had to not be in those meetings, we actually feel ourselves becoming more distant from the team. It's important to be there and participate. And we've now got clear structure, clear inputs, clear outputs, and clear description. So we've been talking about the clinical input, but now we're actually, because the measures are embedded in our practice, what we can do is we can start to describe on an aggregated level what the impact that we're doing is. And you know, we can start to talk about the benefit that being in our service is giving. Now, this is a really good example of where you have to be a little bit cautious in interpreting these kind of data, because you might think, oh, gosh, right, well, I suppose the inpatient centre is probably giving a lot more benefit than community, so community can't be very good, but that's not how these things work. You have to be very careful about how you interpret it, and I think that is an explanation that we as a sector are going to have to keep banging that drum about. These measures are very context dependent, and you have to be able to describe the context in which those services are being delivered. Of course, that will make all our community teams sit up and go, why is that? We'll sort that out. We've got quite a competitive team. They'll be trying to address this. But it's really important to understand the context of this. But you can also then start to look at things like quality of life scores, and if you've got the right technology, you've got the right capacity to report, you've got the right software to help you display, then actually you can describe very effectively what you do. So we're near the end now.
Can I just say one thing?
Yeah.
You interrupted me earlier. What that data's also done, for the first time, we presented that to our management group, and you could see the non-clinicians all go, wow. You could see their pride in the fact that they're working in an organisation that is making a difference. And for our team briefs in December, we're going to be sharing it with the whole of the organisation, because we talked about that organisational change and the culture change. Well, actually, that's a great accolade to the whole of the team, not just the clinical teams, for the difference that hospice makes to Sheffield patients.
Yeah. That our service is made up of our fundraisers, our back office staff, our clinical teams. Hospice can't exist without all of that. So it's fundamental that they share in the good news of being part of that process. So, for us, this goes back to this document, Delivering Benefits of Digital Healthcare. Maybe we should just call it Delivering Benefits of Good Healthcare. And, I think that what it's really saying is the lessons for success, and we think, I think we have to be proud of the work our teams, not undermine the work our teams. We are proud of the work that our teams have done in taking this forward. And the lessons really here are, it's about transformation. It's about culture change is crucial. The users need to be involved. Reporting is fundamental. That there's a continuous learning cycle, that ideally you need to be interoperable. We're some way from that yet, but we'll hopefully get there. And really, this is about governance. These are all the lessons we've learned on our journey to this point. Fundamentally, what it's done is allowed us to change really quickly. And this is just a really quick slide. This was our nursing structure under Judith before. This line for ease, that is here, has been shrunk into one box. But actually that had 9.2 whole-time equivalents, all on one level, flat structure, going all the way along, all effectively directly managed by the lead nurse. And what we've got now is this. And really this is a change in structure and a change in workforce that is directly fed by the implementation of the MDT structure and the benefits in efficiency and learning and workforce change and workforce challenge. And underpinning all of this is our way of MDT working and IPAWS. And Oak. And so these are the differences that this makes to us, and it sets us up really to address the challenges for the workforce.